video?
Yes, ma'am. Yeah, I'm here, ma'am.
Okay.
Chitra, can we start?
Yes, sir.
Yeah,
Yes.
Rajesh ma'am, with your permission, shall I start?
Yes, sir, please.
Yeah, thank you, ma'am. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare, and I welcome you all on behalf of Shield. And on celebrating very essence of women all over the world, on the occasion of International Women's Day, we cordially invites for your CME with Foxy Kalbugi and Kalbugi OBG Society along with Shield Connect. So for further proceeding, I hand over the session to Dr. Sneha ma'am to take over the session further. Yeah, over to you, ma'am.
Yeah, thank you. Thank you. I think my screen is not being shown. Good evening, everybody. Good evening, my teachers and my seniors and my colleagues. First of all, a happy Women's Day to all the women over here. And this is a very auspicious occasion for all the women. And thanks to our ma'am for organizing this CME tonight. So by not wasting much of time, I would like to call upon Dr. Rajshri Paladi ma'am to introduce the chairperson today and also welcome the CME. Today's CME would be in two sessions, one with the diabetes and pregnancy and second with the contraceptive practices. So let's begin. Over to you, Rajshri ma'am.
Namaste, everyone. Good evening and warm welcome to this beautiful session being conducted, which is a focused seminar, a focused talk by two eminent speakers in their respective fields. We have Dr. Serena Gilvas, ma'am, a very senior teacher who actually needs no introduction is in the postgraduate circles of teaching and learning. She herself is a embodiment of knowledge and very graciously she has accepted to be one of the speakers in today's session. Ma'am, hearty welcome to our session, and I'm extremely honored that you'll be addressing our society today. Another speaker of equal repute and who has been doing a wonderful work in the field of contraception and family welfare, Dr. Shobha Gudi ma'am, a dear friend, elder sister, and guide always in the Kasauga activities, who is very passionate about what she does in her work and a very, very dedicated person in the activities that she carries on. And to chair these two important sessions, we have Dr. Kasturi Donimat, another dear friend and close to heart from Hubli, who is the president-elect. A warm welcome to you, ma'am. And Dr. Savita, thank you. Again, another good friend who is heading the Vani Vilas Hospital and head of the department in OBGYN in Bangalore Medical College, and our association runs a long way behind. So we have an embodiment of Shakti today, delivering the Saraswati, Ma Goddess Saraswati, and being attended by all the beautiful women. And what a coincidence, what a beautiful coincidence. This program, which was supposed to be held on 5th due to some inconvenience of the schedule of the timing and the slots, so it was postponed to today, and we heartily accepted, and all the speakers heartily accepted to do it on 8th. And this day being celebrated as a Women's Day, to acknowledge and honor the woman and to recognize her presence in the current modern day society. Actually, it fails me to understand why that a particular day is being celebrated as a Women's Day, because we know that a woman's role is way beyond one day. Ever since the creation, it's just the Adi Shakti or the Ardhanarishwari, that it is both the man and the woman which form the human race and the existence. But still, because of certain reasons, that it had to be restated and it has to be reassured and brought into the highlight that women need to be acknowledged and women have to be celebrated. Very well, we are there, whatever, irrespective of the roles that we play. And I think as an obstetrician, the toughest and the most important job would be to balance our activities, deliberating all the responsibilities that we have, be it a mother, a wife, a daughter, a sister, and most importantly, an obstetrician who goes at the beck and call of the middle of the night or the day, anytime, just sheds her household or her personal activities and be there for the safety of the mother. And that is what we have chosen upon, and that is what we would try to educate ourselves more and better. And that is the reason that every month in Gulbarga OBG Society, we have been having 2 focused speakers. Initially, we had a postgraduate teaching program. We also had the youth talent who were choosing upon one topic and giving a lecture. And these 2 topics were left untouched yet. So Dr. Serena Gilbas ma'am happily agreed to do this talk, and also Dr. Shobha Gudi ma'am to speak upon the contraceptive choices. So a hearty welcome to all our speakers, to our chairpersons and the delegates who have joined for this very interesting program today conducted by the Kalburgi OBGYN Society. Can I have the first slide? Dr. Kasturi. To chair this session, before that, we have a small video about the Women's Day. Thank you for that lovely video, Chitra. We have the first session, Diabetes in Pregnancy, by deliberation by Dr. Serena Gilbas, Professor and HOD, Jubilee Mission Medical College and Hospital. And this will be chaired by Dr. Kasturi Donimat. Can I have the slide, please? Dr. Kasturi Donimat, Professor and HOD, KIMS Hubli, President-elect Kasoga 2021, Ex-Secretary General Kasoga, Ex-Treasurer of Kasoga, Ex-President of Hubli and Dharwad OBG Society, Secretary General Hubli Dharwad OBG Society, Co-Investigator for International Research projects, MCI Inspector to many colleges all over India, UG and PG Examiner at many universities, Chairman of General Students, General Activities of KIMS Hubli, Chairman of Graduation Committee KIMS Hubli, TOT Trainer, Faculty at many state, national and international conferences, conducted the very successful popular Gnana Harsha Kasoga PGCME for the last 5 years, and most of the postgraduate students from all over the state take this opportunity to train themselves just before going for the exams. And Dr. Kasturi has conducted many workshops, CMEs and conferences. Over to you, Kasturi ma'am, to chair the session by Dr. Serena Gilbas, and please introduce madam.
First of all, thank you for such a nice introduction, Dr. Rajeshwari, and a pleasant evening to one and all. And first and foremost, a very happy International Women's Day to all of you, especially Gulbarga OBGYN Society President, Secretary, all the members, all the postgraduates, all the faculty, chairpersons, and also the Kasoga members. I could see Patron and Nagraj sir, and many who were Kasoga EC members who have joined. Thank you for this opportunity. And it is a moment of pride and privilege to introduce such an eminent senior teacher, a teacher of teacher, Dr. Serena Gilbas. She is presently professor and head of the department at Jubilee Mission Medical College and Hospital. And she is the president-elect of Kerala Federation of OBGYN for the year 2022 and 23. A very, very prestigious association. She has lots of achievements to her credit. She's into postgraduate teaching since 1994. She has presented and published several papers And she has as a faculty at many of the gynec conferences all over Kerala and all over India. She has organized several workshops on vaginal surgery, ultrasound, and also organized several conferences. She has worked as president of Trishur OBGYN Society in the year 2003 and 2004. She was scientific chairperson for AICOG held in Kochi. Written many chapters in undergraduate and postgraduate textbooks, and she has many awards to her credit. That is JCI Professional Excellence Award 2013. In the year 2015, IMA Best Doctor Award. In the year 2018, Times of India Economic Times Award for the most inspiring doctor. Most inspiring doctor awarded by Chamber of Commerce, Trishur Society, Trishur, and Chairman Board of Studies for UG Clinical, Kerala University and Health Sciences. And in the Board of Confidential Review of Maternal Deaths in Kerala till date. That's very famous. They do confidential inquiry. And as I told you, President-elect of Kerala Federation of OBGYN for the year 2022-2023. With these few words, it's really my pleasure to introduce such a eminent personality, Dr. Sarina Kilvas. Thank you, madam. Yeah. Over to you, madam. Okay. Mute ಆಗಿದೆ.
Is it okay?
Yes, ma'am. Yes, sir. We are able to see your slides.
Yeah, thank you. So good evening, everybody, and a very happy Women's Day to all of you all. President of Kalabag Society, Dr. Rajeshri Paladi, Dr. Sanjana, Secretary, Dr. Kasturi, Chair, Dr. Savita, Dr. Shobha, and all my friends out there. Today we'll go through a very common topic, diabetes in pregnancy. Now, all of you all know that this nomenclature has been changed by FOGSI. Instead of saying diabetes in pregnancy, FIGO has said that it's better to call it hyperglycemia in pregnancy for two reasons. Once, it takes away the bias that you're a diabetic, the word diabetes, okay? And the second reason they say is that, we normally define GDM as abnormal glucose metabolism of any severity seen for the first time in pregnancy. So many times we are confused, is it pre-gestational diabetes or is it gestational diabetes? But I will tell you one thing, when you detect a diabetes in the first trimester of pregnancy, okay, then you should always remember, by definition, you may call it a GDM, but they will behave like a pre-gestational. That word is very important. So in order to take away all this confusion, FIGO has given this nomenclature of hyperglycemia in pregnancy to take away the bias.
Ma'am, sorry to interrupt, ma'am. Your slides are not moving, ma'am. We can see only the first slide, diabetes in pregnancy.
Is it?
Can you please stop share and share again, ma'am?
Okay.
I think all three of you are
Is it okay now?
Yes, ma'am. Perfect, ma'am. Thank you, ma'am.
So when you say hyperglycemia in pregnancy, it's one of the most common metabolic disorders all of us know. And hyperglycemia or GDM is associated with, of course, all of you all know, maternal mortality, morbidity, perinatal and neonatal morbidity, and most important, the late long-term consequences. 1 in 6 live births occur in women with some form of hyperglycemia, and they say that 84% of which are due to GDM. Now, supposing you take a thing of 100 patients, you will realize that GDM is actually about 90% and 10% of them are actually the pre-gestational diabetes or the overt diabetes as we call them. Okay. Now, I will just run through this just to tell you all that FIGO has said that you take the first column, hyperglycemia in pregnancy. So it could be either diabetes in pregnancy, what they really mean is a pre-gestational diabetes, or gestational diabetes. Normally, this begins, the diabetes begins before the start of pregnancy. Then it is very easy to diagnose. But normally we see GDM when it is first diagnosed during pregnancy. But I just want a word on type 1 and type 2. Now, you know what type 1 diabetes is? Type 1 diabetes is due to, it is normally immune mediated. Okay, immune mediated. And most of the times you'll find that it is due to absolute deficiency of insulin. Okay, earlier on, we were using this terminology, dependent and non-dependent on insulin. Now that dependent, that word is taken off. And we call it the type 1, which means absolute insulin deficiency. And the type 2 is actually, many of the times it is a secretory defect, but mainly due to insulin resistance. So if you ask me in different words, the diabetes in pregnancy, the GDM is actually type 2 revealed in pregnancy, okay? So that's what I wanted to tell you all. And gestational diabetes normally we see in the second half of pregnancy. Now, there is a lot of thoughts about whether we should follow the WHO criteria or we should follow the IAD-PSG, that is International Association of Diabetes in Pregnancy, study groups and so on and so forth. Now, I'll make it very simplified for you all, okay? Now, when a woman comes to you prior to pregnancy, she is a known diabetic, and then she tells you, doc, I want to become pregnant. So what all should you go into? One is get a good obstetric history, get a complete medical history. And you saw those names I put there: retinopathy, nephropathy, neuropathy, and cardiomyopathy. These are the 4 end organs which diabetes can damage. And in that, if you ask me, I will give my preference to the first 2, retinopathy and nephropathy. Now, retinopathy, it can be actually non-proliferative, or it can be pre-proliferative, or it can be proliferative retinopathy. The first 2, it doesn't matter. But when I say use the word proliferative retinopathy, that means there is neovascularization. That means she can bleed into the vitreous. She can have a vision problem during pregnancy. So always, if you think that she's got a long diabetic age, check out her fundus before she becomes pregnant. And if you see any neovascularization, do a laser photocoagulation. Okay, then she can lose her vision in pregnancy. Now, nephropathy. Nephropathy is one thing which you will always see by seeing the microalbuminuria. Now, anything to do with the kidney in pregnancy, any disease of the kidney in pregnancy, normally may not have much of a problem if there is no hypertension. So if they've got a nephropathy, so that means you've had the microalbuminuria, you've got the raised creatinine, etc. And if you find she's also got hypertension, then the prognosis is bad. Okay, so remember, proliferative retinopathy can worsen in pregnancy, and diabetic nephropathy can worsen in pregnancy. And very bad if it is associated with hypertension, because all of us know that's called secondary hypertension. Okay, neuropathy really doesn't matter so much. Okay, and cardiomyopathy we rarely come across, so that doesn't matter. And when you come to the drug history, many of these women have got a pre-gestational diabetic, could also be a hypertensive, and she could be on ACE inhibitors. So remove the ACE inhibitors and statins. These are 2 no-nos in pregnancy. Okay, you should not give an ACE inhibitor, and any statins she's on, you've got to stop it. And change the oral to insulin. Now, all of you all know there's one important thing about insulin. When oral can cross the placental barrier, insulin will never cross the placental barrier. That is the most important quality of insulin. So that is why whenever a person is pregnant, we change over from oral to insulin. Then you check the HbA1cs, the fasting blood sugar. Educate her about insulin intake and self-monitoring. If she is very obese patient, tell her to do the weight reduction, go with an ideal BMI. Check her thyroid, because if she's a type 1 diabetes, she could also be having some immune thyroid problems too. And the target values of HbA1c is 6.5%, less than that, and the fasting less than 95. And let me tell you at this point of time, HbA1c normally will tell you indirectly what the sugars are like. 6 is equivalent to 120 blood sugar. So with every 1 over that, it's plus 30. So 7 HbA1c will be actually 150. 8 HbA1c will be 180. The sugar will be around that. 9 will be around 210, and so on and so forth. And if at all you want to have one aim in treatment of a diabetic patient, let her fasting be less than 95. Please remember that. And your next treatment is a postprandial 2 hours, 2, easy to remember, 2 less than 120. That's our aim even in the treatment. So this should be your take home. Whenever you check her sugars, make sure that her fasting is less than 95 and her 2 hours is less than 120. Okay, easy to remember the 2 because it's a 1 hour which is 140. So forget about the 1 hour. It is, if you must have a 2 hours fasting, 2 hours postprandial less than 120. Okay. Now the screening strategies, all of us know a lot. We know about the ACOG's two-step screening. We were all doing it earlier, the 50 grams and then later on the 100 grams. But today we don't do that. We all follow the DIPSI. I'd like to tell you all a word about the HAPO trial and the IAD-PHS screening. Now, diabetes in pregnancy study group of India. This we all do as a one-step, very convenient, practical, cost-effective, irrespective of the fasting and the non-fasting stage. It is done any time of the day. You normally give a challenge. That is, we give a 75 grams of glucose load. And this is actually anhydrous glucose. You mix it in 300, up to 300 ml, 200 to 300 ml of water. And you must consume it within 5 to 10 minutes.
There is a disturbance from Dr. Radhika. Can you please mute? Dr. Radhika, please mute.
Okay. So we give 75 grams, and please remember this. If she vomits within half an hour, you've got to postpone it. You can continue with the, sorry. If it is within half an hour, you will have to, you can do it on another date. But if she vomits after half an hour of taking the glucose, then you can actually continue with the test. Okay. So what do we normally do? We do a 2-hour post-glucose venous plasma. But today, the FOGSI has said you can also take the capillary blood sugar for the DIPSI. Okay. And the GDM is when it is more than 122 hours after 75 grams. And we call it overt when it is more than 200 milligrams per deciliter. There is also another terminology which is called GGI, gestational glucose intolerance, GGI, that is between 120 and 139. Okay. And normally what do? We do DIPSI in the first trimester. All of us know the reason why, because the fetal pancreas starts secretion by about 11 weeks. So if there is a hyperglycemia and goes undetected, then the fetal pancreas will start becoming hypertrophied and start secreting a large amount of insulin. And later on, it's bad effects. Okay. So we must do it in the first trimester. Then if that is negative, then you repeat it 24, 28 weeks, and then again in the third trimester. Now, the details of the HAPO and the aftermath. See, HAPO trial, I just want you all to know one thing about the HAPO trial. It is actually hypoglycemia and adverse pregnancy outcome. Why that was given so much of importance was always in all the trials that were conducted, we thought of the long-term outcome. We never thought of the immediate adverse effects. HAPO told about the immediate adverse effects. That is, at birth, how the mother was, how the fetus was, the weight of the fetus, the hypoglycemia, and the C-peptide levels, etc., etc. So that is why HAPO had a lot of importance. And after they noticed that high blood sugar levels could produce adverse pregnancy outcomes, they said we must reduce our threshold. So that is why HAPO became very prominent. The hypoglycemia and adverse pregnancy outcome, that is, I told you, the immediate adverse outcome of pregnancy. It provided evidence for GDM diagnostic criteria to clarify the relationship between maternal hypoglycemia and adverse. It was a 7-year international study, 23,000 women. But see what they did? They did a 75 grams and they did a fasting, that is 0. Then after 1 hour and after 2 hours. So after, they took 3 values, but any one abnormal value was said to be diabetic. Okay. And this study was done between 24 and 32 weeks of pregnancy. And what did they say? They looked at the primary outcomes, birth weight more than the 90th centile, Cocs, C-peptide, which told you about the fetal hyperinsulinemia. If it is more than the 90th centile, neonatal hypoglycemia, that means clinical hypoglycemia of the fetus, and the primary cesarean rate telling you that the baby must have been really big. There were also secondary outcomes. I don't know many of the postgraduates, if you're interested in, the secondary outcomes were actually a preterm labor, preeclampsia, hyperbilirubinemia, shoulder dystocia, and traumatic delivery. So that was a secondary outcome of the HAPO trial. Now, the results, the linear association between the increasing levels of fasting 1 and 2 hours glucose values to all 4 primary outcomes and the 5 secondary outcomes, as I told you. Now, after the HAPO trial, then they decided that the IADPSG, the WHO, everybody started questioning, shouldn't we reduce? We always thought of 95 as the fasting, they reduced it to 92. Okay. And then the 1 hour, which we said is 180, they kept it as 180. But the 2 hours, which we said is 155, they reduced it to 153. So 95 became 92, 92, 180, 153, and any one abnormal value was told to be diabetic. Now, that's what I've told you in this slide. So the converted results of HAPO to practical guidelines. All women not diagnosed as overt or GDM earlier were given a 75 grams. And when you do the fasting, then it is called the oral glucose tolerance test. So the fasting and the 1 hour and 2 hours, and as I told you all, the cutoff was reduced from 95 to 92. The 1 hour remained the same, and the 2 hours more than 153. Any one of the 3 values met or exceeded was GDM. Okay, so the IAD-PSG criteria is based on the outcome in neonates. It is a one-step procedure, and it decreases the threshold, and it identifies the more number of mild GDMs, and it did improve the outcomes, but they always used one terminology that we overdiagnosed diabetes. Okay. Now we all know this, that increased incidence with diabetes, you have preeclampsia because they enjoy the same comorbidities, like they are obese, they are the same patients who are diabetes also can have a preeclampsia. Infections are more operative delivery, more traumatic. Cesarean is more shoulder dystocia because of the asymmetrical macrosomia. The shoulders and the trunk are very big. The prolonged labor, the vasculopathies, like I said, told you all, the retinopathy, the nephropathy, the coronary artery disease, the DKA, and the type 2 diabetes later on in life. Again, when undiagnosed, when went in for miscarriages, preterm births, I just want to add one word about preterm birth and diabetes. When you have got a preterm labor and she's a diabetic woman, please remember, try not to give the beta sympathomimetic drugs. It can, many times for these patients, we also give a steroid, right? Steroid and this is a very dangerous combination. It can push the scale towards 1, pulmonary edema, and 2, a diabetic ketoacidosis. So if at all you can avoid a beta sympathomimetic drug, it will be very good. You can give nifedipine, you can give magnesium sulfate, you can give indomethacin before 32 weeks. Okay. So, and of course, etrosibane if it's available to you all. Then congenital malformations, we know that you can have CNS, CVS, abdominal defects, you can have renal problems. Everything is there with diabetes. Altered fetal growth. We normally find macrosomia, but you can get an FGR if there is an associated hypertension with the diabetes, or if you have also got a vasculopathy or end organ damage in diabetes, then you can get an FGR. Unexplained fetal demise, all of us know it is due to the fetal hyperglycemia, and many of them go in for stillborn babies, and of course the polyhydramnias is also there. So, and the neonatal problems. The neonatal problems we see this RDS. That is a respiratory distress syndrome, and you will find that it is because the diabetes brings about a delayed lung maturity. But please remember, RDS is more so when you do a cesarean. They say that when they have a vaginal delivery, it squeezes and lets out the fluid. So the RDS is less after a vaginal delivery in a diabetic. Hypoglycemia, all of us know that there is a fetal hyperinsulinemia, maternal hyperglycemia, it comes to the fetus, and then there is a fetal hyperinsulinemia. But after birth of the baby, there is no more maternal glycemia, hyperglycemia. So the fetal hyperinsulinemia will push the baby towards hypoglycemia. That is why early feeds are so important. And the cutoff for hypoglycemia in a diabetic is 45. Okay. Hypocalcemia when it is less than 8. Hyperbilirubinemia and polycythemia. Remember, polycythemia, there is a little hypoxia and it always pushes a lot towards erythropoiesis and thing. You can also get necrotizing enterocolitis in these women with polycythemia, and they can also go into renal vein thrombosis of the baby. There is hypertrophic cardiomyopathy, but hypertrophic cardiomyopathy, it might become normal after a month or so. So check out the baby again, do an echo on the baby after a month. Then of course, all the injuries and then the long-term effects. Please remember, there are 3 bad effects of hyperglycemia on the fetus. In the first trimester, you can get congenital abnormalities. In the second trimester, hyperglycemia can bring about long-term cognitive development impairment. And in the third trimester, hypoglycemia can bring about a macrosomic fetus. Okay. And of course, the type 2 diabetes in later life. So the medical nutrition therapy, the MNT is what we always call it, the cornerstone of treatment. A dietitian should be consulted. That should be, whether you give insulin or not, you should remember 2 things. You must give the diet plus insulin. You must give the diet plus your metformin, whatever, and also exercises. Okay, I'll tell you a few words about that. So dietetic restriction is very important. Carbohydrate restriction, especially the simple sugars, should be avoided, and restrict weight gain. Now we distribute it as 10 to 15% breakfast, 20-30% lunch, 30 to 40% dinner. Okay, so 3 major meals, and every snack in between is 10%. That is how you distribute the calories. Severe dietetic restriction can cause ketonemia and poor intellectual development in the fetus. So remember, they always say that don't reduce the total calories to less than 1,800 kilocalories. Okay, we'll have to calculate the kilocalories they require and should never be less than 1,800. Then it can push them more towards ketonemia. Dietary intervention usually prescribed for 2 weeks, the initial 2 weeks, and see whether she responds. How do we see that you respond? I told you in the beginning, check her fasting blood sugar. If it's less than 95, good. If the 2 hours is less than 120, good. That means she's good with diet. So every time she comes, she must bring a paper with the fasting and the 2 hours postprandial. If pregnancy is advanced and one cannot wait for 2 weeks for a trial, then change out insulin. They also say that, if you see a diabetic patient before 20 weeks, maybe she's better off with insulin. If you see her later on in pregnancy, after 30 weeks, maybe she's better off with insulin. If she's not well controlled with metformin, maybe she's better off with insulin. If she's got excessive weight gain, maybe she's better off with insulin. So these are all the things which they have probably said when you have to choose between the oral and the insulin. And in a patient with very high blood sugars, especially the high fasting blood sugars, insulin is to be started. Okay. Now, I want to tell you all a few words about glycemic index. Now, glycemic index, whenever you buy a food product, you look at the GI. Okay. Remember just 2 numbers. If any food product is more than 70 GI, that means it's a very high glycemic index. If it is less than 55, it is low GI. So you can buy the foodstuff which has got less than 55. If it is more than 70, that means she's got a high glycemic index. And we'll go through some foodstuffs. All these. Milk is not so bad. You got it. Milk, and whether it be whole milk or skimmed milk, it's not so bad. But look at dates. Dates is 103 GI. So don't take dates, okay? Then when you look further down, among the fruits, you can take apple, banana, grapes also not so bad. Mango, slowly it is. But look at the pineapple and watermelon, very high GI, okay? Now look at the rice. White rice is very bad, 89 GI. But look at the brown rice. So that's where they always say, take the brown rice. And then when you look further down, see, noodles and all that is not so bad, but look at the potatoes. Look at the honey. Honey is 90 GI. So now you know where to, and a good thing that you can take is fructose for the sweetener. Okay. So we normally, if it a person with a normal BMI, it is 30 kilocalories. If she's got less BMI, then we give more kilocalories. And if she is obese, you give them less. It's opposite. Okay. And then, of course, we give them 40% carbs, 20% proteins, and it's 40% fat. It's not 20%, sorry. So food with low glycemic index to be consumed, 3 meals and 3 snacks. The reason being, when you don't have the snacks, they will tend to eat a lot. So what happens? The postprandial sugar will go up. And the postprandial is what is really very bad for a diabetic mother. So when you give a snack in between, she'll eat less and the postprandial rise will not be so much. Okay. Now, the drug which is insulin is the only drug approved by the FDA and only available drug for overt or pre-gestational diabetes. Only human insulin is used now, okay? And insulin replacement is designed to mimic normal physiological release of insulin by the pancreas. And I just want you all to remember these two. I'll just ponder a little on insulin. There are two types of insulin, basal insulin and prandial insulin. You know what basal insulin is? Throughout the day, okay, throughout the day, there is always a hepatic glucose production. So always you'll find little amount of sugar throughout the day and in the fasting state. So these two are taken care of by NPH, the intermediate insulin. Okay. So if you want to reduce, just take one shot of NPH in the night and it will take care of your fasting next morning and also the in-between meal, the sugar levels. Do you understand? The prandial insulin are those excursions of high glucose soon after a meal. So in this, what do? You take the rapid acting insulin analogs. Okay, the RA, I'll tell you about that. So basically, there are two types of insulin. That is the old insulin, which we always saying the regular and the NPH. That is one category. And then the insulin analogs. In the insulin analogs, there's something called the rapid acting insulin analogs and the long acting insulin analogs. Okay. Now we are always using the insulin analogs. Now look at that. That is the old one, which I told you, the regular. It takes about, it's 30 minutes or so for it to start its action, and its action lasts longer. And many times we are giving the regular and the NPH. You can give a combination like that. But many times people are going for the rapid acting. The rapid acting, see, within 5 to 15 minutes, you know, a simple way of saying, how will you take Lispro, Aspart, blue leucine, we do not have much of a study about, but Lispro and Aspart are very commonly used. They say, take it along with the meal. Take it along with the meal, the insulin. You take the shot and immediately you go with the food because it's so fast acting. So, and then its action lasts for about 4 to 6 hours. But look at the long acting insulin, the Glargine and the Determer. The problem with this is its action lasts for about almost 24 hours. Then you might think, isn't that a better insulin? But the problem with this insulin is it doesn't peak. So it doesn't take care of the postprandial rise. That is the problem with the long-acting insulins. That is why it is still not very popular among diabetic treatment in pregnancy. So the long-acting insulin analogs and the rapid-acting insulin analogs. Now look at that graph. That first graph tells you about the rapid-acting insulin like the Lispro, Aspart, etc. See how quickly it goes up and it comes down. Okay, so you should take it along with the meal. It will quickly take care of the postprandial rise. And why that is important is because if you have got a postprandial rise after breakfast, the pre-breakfast rapid-acting you can increase. If you take a post-lunch and if it is very high, the pre-lunch rapid acting is slightly increased. If the post-dinner is high, you just increase that. So the best combination is like this: 3 rapid acting and 1 NPH at night. That is a very, very good combination. You and I can take care of it. We don't require an endocrinologist for that. Do you understand? Another combination is the regular and the NPH. How do they take it? They calculate the total amount of insulin and 2/3 and 1/3. And this is a combination, it's a mixture. So they take 30% of the regular and 70% of NPH in the morning. 2/3 of it is given in the morning and the remaining 1/3 is given in the night. But the night dose, it is not 30 and 70 combination, it is 50-50 combination. So that's all that you need to know about diabetic treatment by insulin. Either you give the 3 rapid acting insulin and an NPH at night. So the NPH will take care of the basal levels of glucose as well as the fasting. So if the fasting is high, you find out whether it is the Sumugis effect or the Dawn's effect, and either you'll have to increase or decrease the NPH. Okay. And then the regular, I told you, if the post breakfast is more, increase the pre-breakfast. The post lunch, increase the pre-lunch. If post dinner, and the NPH is taken at bedtime. Okay. But look at the Determer and Glargine, look at the curves. It goes on like this. It's good for many of the regular patients, but not so good in pregnancy, though there are people trying it in pregnancy. So as I told you all, basal is the NPH insulin, an intermediate acting insulin for controlling the basal hyperglycemia, and the prandial is a rapid acting, which is the Lispro and the Aspart for controlling the postprandial. Now a word about the oral hypoglycemic drugs, glyburide, metformin, or what is the combination? I mean, what is the thing between glyburide versus metformin and the others? Now, when you take the first OHA that was tested is like all of us know that it was metformin. And today everybody will swear by metformin. If you take any diabetic, whether it's pregnancy or non-pregnant, you will always find that there is a metformin combination. Every pregnant woman and every diabetic person is normally started on an insulin sensitizer. Okay, so that's insulin sensitizers metformin. Metformin is there in every diabetic pregnancy. I mean, in every diabetic patient all over the world. And along with that, people add on insulin. It is a second generation sulfonylurea, insulin secretagogue. Increase in insulin secretion and sensitivity in the peripheral tissues reduces the hepatic glucose. If you ask me what is the action of metformin, I will say it reduces the hepatic production of glucose. Now, you and I know that hepatic production of glucose is the one which keeps the sugar there throughout the day. So it reduces that. Do you understand? And its peak action is achieved by 3 hours. And we have compared, Langer et al. Has compared GDM management with glyburide versus insulin, and glyburide glyburide was equivalent to insulin in achieving the glycemic control. And glyburide comes as a, what is it? It's a category C drug, whereas metformin is actually a category B drug. And breastfeeding is not contraindicated. I will say that if you are in a low resource setting, you can go in for glyburide, okay? Because they said it is not inferior to insulin. You can start on, supposing you are in a PHC where, you know, you don't get women who are educated enough to check the sugars, etc. At least put them on a glyburide, 2.5 milligram BD, 5 milligram BD. Max, you can give 10 milligram BD. That is a dose of glyburide. And as I was telling about metformin, it's a biguanide derivative, it's insulin sensitizer. It inhibits the gluconeogenesis. And we all know about the metformin in gestation study, that the TOFU actually stands for the offspring study, the follow-up, the offspring follow-up. And they noticed that the metformin was equivalent to insulin in attaining euglycemia. The neonatal outcome was similar and less. The most important thing was two things. There was no increased maternal or fetal weight gain. That is very, very important. And the second advantage of metformin was there was no too much of hypoglycemia to tackle. So that is how metformin, even though those on metformin required more amount of insulin compared to glyburide, you will find that with glyburide, the babies were bigger, whereas with metformin, the babies were not so big. With glyburide, the weight gain in the mother was also more and in the baby was also more, whereas it was not so much with metformin. And at 2 years of age, both had the same body fat distribution, but metformin group had a larger subcutaneous fat. When I say the failure rate, it is not actually the failure rate. You may have to add on in 46%, you may have to add on insulin. So when you see a raised, your DIPSI reading, say about 150 or so, you immediately start off on metformin. And then you just see how it is. And I told you, check the fasting, it should be less than 95 and 2 hours less than 120. If it is okay, then you can continue with metformin. Okay. Now, there is no adverse effect. Just do not directly cause maternal hypoglycemia, which is a very good advantage. And you can give it safely during breastfeeding. And we all know the combination. It's 500, slowly increase, 500 TDS. Then if you want to go to 850 BD, you can give 1000, you can give 1000 BD and all that. They've always said, the ACOG always says that metformin should be given according to the BMI. If the patient is obese, then you'll have to give more amount of metformin. So there are many studies that have said, and metformin and glyburide, and we find that they're almost equally effective, though because we have used metformin more, we continue to use metformin more. There are other alpha glucose, you know that, no, acarbose maybe, it may come as an option for the future. It decreases the postprandial glucose. All of us, we want to decrease the postprandial. And there are studies that are coming out in that. So glyburide and metformin are effective treatment options for GDM, although insulin remains the only FDA-approved agent. Pre-prescription counseling is a must. You must tell them to maintain and check out their sugars with the glucose prick. And I can tell you this metformin and glyburide, actually, it doesn't require any storage. It is off the shelf. Okay. That way, I want to tell you all a thing about insulin. Insulin should always be refrigerated. The cartridge should be kept at the door. So because about 2 to 8 degrees centigrade is the thing. And once you open it, then maybe you'll have to finish up using the cartridge within a month. So there are 2 conditions in which you throw away the cartridge. If by any chance you have frozen it, then throw away the cartridge. You should not be using it. For any reason, you're going to use it for more than a month, throw away the cartridge and take a new cartridge. That's one. And try not to expose his insulin vials to heat and sunlight. Try not to expose them. So there are people in low resource settings, they say keep it close to a pot, keep the insulin vials close to a pot. There are people who put it in Ziplocs and even keep it in earthen pots with water. Do you understand? So keep it in a cool place and close to drinking water pots or earthen pots, etc. But keep it in a cool place rather. Okay. But whereas metformin and glyburide, you do not have to do all that. You can actually be using it off the shelf. Insulin, as I told you all, the usual dose in labor, the usual dose of the intermediate action, the insulin is given at bedtime. On the morning of the labor, that morning dose of insulin is withheld. You start with normal saline and keep, I'll just tell you one word, keep the blood sugar around 100. Okay. I just would like to tell you one more thing at this point of time. When a patient is a GDM, many times we do not have to give all this. All what I've told you, normally the ones who require it will be the ones with over diabetes. Haven't we noticed our GDMs? We really don't. We just keep checking. Every hour they say in the second stage, 1 to 2 early. The early phase, you can check it 2 hours early, and towards the second stage, you can check it once in an hour. Okay. So you can do the glucose prick and you can check it. But what I've given you here is normally what a pre-gestation would require. So keep it around 100. And then you can actually give the regular insulins, as I've told you all. When the sugar is between 100 and 140, give 1 unit per hour. 141 to 80, 1.5 units. 181 to 222, and more than 220, you'll have to give 2.5 units. Now, what do we do after delivery? After delivery, don't do anything the first 2-3 days. They say that after you have started a normal diet, after 3 days only should you start metformin if you have to. Insulin requirements will actually drop by about 50%. So try not to do too many things. The first 3 days, just check the fasting and the random blood sugar or anything, whatever suits you. But by the end of 6 weeks, you must do a 75 grams, 2 hours OGTT, and look at the values down. We take the WHO's value 126 to say that she's a diabetic, and more than 2 hours, 200. This value holds good even for pregnancy. If you get a fasting of more than 126, they say that probably what you're dealing with in pregnancy may not be a plain GDM, it may be a pre-gestational. Do you understand? So also the 2 hours, if it is more than 200, even in pregnancy, it tells you that it could be a pre-gestation. So now if it is more than 200 after 2 hours, then probably you'll have to think that she's a diabetic. Then of course, every year, then once in 3 years, and then definitely you must check them pre-pregnancy. Before her next pregnancy, you must check them. Make sure that she enters pregnancy with the euglycemia, because I told you in the first trimester, hyperglycemia is teratogenic. I told you some time back, in the second trimester, it can produce neurocognitive effects. And in the third trimester, it can produce a macrosomia. So remember, try to keep your sugars down as much as possible. Keep your HbA1c down. And I'll tell you one more thing at this point of time. HbA1c again is more for a pre-gestational diabetic. It has not got much of a value for a gestational diabetic. Okay, remember that. So friends, with that I conclude. Thank you.
Kasturi ma'am. Kasturi ma'am. Okay.
Yeah.
Kasturi ma'am. I think Dr. Kasturi ma'am, I don't see her on the screen. Serena ma'am, excellent presentation, very, very practical and informative talk. And we are extremely happy that we could gain so much of knowledge right from the nomenclature, from the reschedule of the title to the definition and various effects and impacts of having the glycemic control and the HbA1c value, which can indirectly show us the values of sugar just by doing the HbA1c. Excellent presentation, madam. I think most of our viewers have been greatly benefited by this very, very clear and lucid talk. Practical tips and take-home message, including the details about the insulin, the type of insulin, the storage and the dosage, etc. Thank you very much, ma'am. Do we have Dr. Kasturi ma'am for her comments? Any doubts, anybody, please put up in the chat box so that we can take it at the end of the session. There is one doubt from Dr. Nagaraj, anhydrous glucose to be given.
Yeah. So actually what you do is many times you will have to see that your pharmacy stores the 75 grams. It's not easy for us to measure the 75 grams. So like earlier on, we were actually storing, it comes in small packets, right? So you just, and then you may mix it in water and you have it. So it is good that you have it within 5 to 10 minutes, as I was telling you all earlier. And normally, if you think the patient is going to vomit, etc., you can squeeze a little lime into it. So then it takes away the bad taste. Don't give it in more than 300 ml of water, between 200 and 300 ml, and you can just mix it and take it. So once we started the 75 grams, our pharmacy has got only 75 grams. So either we say that we want a 75 grams GCT, or if you want to do an OGTT with 75 grams, and I told you the cutoff, then we do the fasting 1 and 2 hours, 92, 180, 153. And any one value, we take that as thing. And I told you all that if the fasting is more than 126, and if the 2 hours is more than 200, probably you're not looking at a plain GDM. It may be a pre-gestational diabetic. Okay.
There's another doubt. Ma'am, you said better to avoid steroids for lung maturity in preterm diabetics, but in diabetics, lung maturity is delayed. So due to delayed surfactant production, so what do in such scenarios?
Yeah, very good. See, we have got 2 types of steroids which we can give. Okay. Now, today we all prefer the DEXA, right? So we give DEXA 6 milligrams, 12th hourly, we give 4 doses. But now what actually happens is you will find that if she's a bad diabetic, it will go haywire. So you will have to remember that on the first day, you may have to increase insulin by about 20 to 25%. On the second and third day, you may have to increase the insulin dosage from 40 to 50%. By about the 4th day, you'll have to increase it to about another 20%. By the 5th day, you'll have to by about 5 to 10%. And 6th to 7th day only, you'll have to taper off the insulin. So remember, it takes about 6 to 7 days. You've got to closely monitor her insulin sugars when you're giving her steroid. Now, I can tell you one thing. Suppose she's a very mild diabetic, it may not matter so much. But it matters when she requires large doses of insulin and you're forced to give a steroid. That is the time that you'll have to follow the schedule. For the small thing, don't bother. Just keep monitoring and it can go on without much of a problem. But if the sugars are very high, now when do we say that a patient is a bad diabetic? They say when you require more than 100 units of insulin is bad. They also say that if a person requires more than 20 units of insulin per day, refer her to a higher center. You understand? So smaller dose of insulin, you can take care of in a smaller setup also, but if she requires more than 20 units, transfer it to a higher center. And anybody requiring large doses, don't you say sometimes they take 50, 60, 30, that's already more than 100. That's bad. Okay.
Okay. Dr. Anita Rajoria has a congratulatory note and she also has a doubt. Any experience with glycosylated albumin?
No. I don't have any experience with glycosylated albumin, but I just want to tell you one thing. There is something else that we can monitor the sugars with. Okay. Just because we all should keep ourselves updated. There is something called a sensor. Now we all know about the prick. Okay. The glucometer prick, the capillary blood sugar. This is a sensor. It actually senses the glucose in the interstitial fluid as well as in the sweat. So that I believe you do not have to do this prick. You can keep it somewhere in the back of the upper arm. It's a small thing like that. And then you do not have to, but not more than 2 weeks. After every 2 weeks, you'll have to change it. Okay, so remember that's called a sensor. So in case your patients come and ask, can I use a sensor? You can use a sensor. Okay, there is one more thing which I wanted you all to know. There's something also called a continuous glucose monitoring and a subcutaneous infusion pump also, which you can give in bad diabetic. So please remember that all these are the in things which people are using, and you'll have to go along.
Question, madam, for that. How frequently to monitor glucose levels in a diabetic woman during pregnancy?
Yeah. See, it all depends upon the level of blood sugar. Now, just imagine I do a thing and I got to 148. I don't have to do a very vigorous monitoring. But supposing a fasting is 200, gosh, I will have to admit her and then I'll have to check it out. You understand? Normally, we say 4-point profile. Okay, 4-point meaning fasting and 2 hours after every meal, 2 hours after breakfast, 2 hours after lunch, you can do the glucomonitor. Okay, the glucose monitoring with the capillary blood glucose. But now supposing your fasting is high, supposing your fasting is high. Now I told you we do not know whether it is a Samogi or the Dawn's effect. Then you will have to do a 3 o'clock in the night. That is a 6-point profile. We do a 6 o'clock in the 3 o'clock in the morning, we do the sugar. And if that sugar shows whether it is Samogi, you'll have to reduce the dose of NPH. If it's a Dawn, you'll have to increase the dose of NPH. You understand? Then in that situation, you may have to do the pre and the post. Now, always we like to have the pre-prandial glucose around less than 100. And the post-prandial, I told you 2 hours, less than 120. Okay. So remember that. And through the night, we'd like to have a glucose more than 60. Okay, so these are all some numbers which you should remember. So if you're checking the 6-point profile, you can do that before and after breakfast, before and after lunch, before and after thing. And that time when you've got a fasting high, then you check the 7-point profile. But otherwise, for a normal GDM, you just check the 4-point profile fasting and 2 hours after every meal. Okay. And whenever the sugars are very high, you shouldn't be the one treating it. Okay. Always get somebody else involved in it. Either you get a physician if you've got a physician, or we get an endocrinologist if you've got one.
And what would be the dose in the postpartum period for insulin administration?
Yeah, so you just check out. I told you, you may suddenly find a drop in the insulin requirements up to 50%. There might be a drop in the insulin. So watch out. It really doesn't matter. You don't have to do a very meticulous monitoring postprandially. Don't take into a hypoglycemia. So just keep monitoring. First 3 days, I told you not much of, don't even add anything. She may not require anything. After that, you check out and see, depending on each diabetic patient is a different person. No? So see if she's been a bad diabetic, maybe she will require even very close monitoring the postprandial. But if she was just a GDM, she may not, you will not even see anything postprandial, post-delivery.
Yes, immediately within 24 hours, the requirement will be nil.
Yeah, certainly. She won't require anything in a GDM.
Thank you very much, madam, for the excellent presentation and clarifying the doubts so very well. I'm sure all the delegates have been clarified of the queries that they had, and irrespective of how many presentations and whatever we listen to, gestational diabetes still remains an enigma, more so because it's on the rise, and India is the diabetic capital of the world, and gestational diabetes has become so very common now. And I think we have Dr. Kasturi, ma'am. Ma'am, your comments?
Yeah, thank you, Sarina. Excellent lecture. Lots of take-home messages and very practical. Your talk was very, very practical. Means it will help all the youngsters, everybody, to actually on ground level what they have to do. You know, it's really very important. And as Madam told, in the past, diabetes was so rare. When we were postgraduate students, hardly we used to see one case. If one case is there, all of us would. But now it is so common. Every alternate patient is diabetic. So the present youngsters should know how to screen and how to manage effectively. Every other patient is going to be diabetic. So very well taken message. Excellent talk, and lots of ground real carry home practical tips. Thank you, madam, for that excellent lecture.
Thank you so much, ma'am.
Yeah, sure.
Can I say something?
Yes, ma'am.
Yeah. Thank you, Sarina ma'am. It's such a pleasure listening to you, and I always learn a lot whenever, as Kasturi said, it is very practical, and I think you bring in the finer tips, for day-to-day management. I just wanted to add here, Rajeshri, that it's the miracle of normoglycemia following delivery. I take this as a tool for counseling, and I tell them, see, every pregnancy puts you at risk. For hypoglycemia, it's a propagative disease.
Yes.
You're endangering the next generation also. And I use GDM as a tool for promoting more contraception. I'm guilty of that. But then I find it useful because it's really miraculous how pregnancy puts them at risk for hypoglycemia. And as Kasturi said, it is today the commonest complication in pregnancy. It's more common than anemia also.
Yes.
So much we are seeing. And at least if not, it's frankly positive, at least it will be deranged. So there is some problem with that. Pandemic has somehow made it worse. I think because there has been a lot of sedentary lifestyle, probably that, and eating habits have not been okay. So the lifestyle going for a shift has led to a lot of increase in GD and IP. And thank you, Sarina ma'am, for the wonderful lecture.
Excellent presentation, ma'am. Thank you so very much
Thank you. Thank you
for
so much.
bringing out the simple, practical, and applicable points. Thank you so much.
Thank you. Thank you.
Thank you, ma'am. Shall we move on to the next speaker? Sneha, unmute yourself, please.
Thank you for this elaborative and very clear explanation about the concepts. Thank you so much, ma'am. And now we move on to our next session about contraception. And I would like to call Dr. Paladi ma'am to introduce our next chairperson. Over to you, ma'am.
Yeah, the next talk is contraception. And to chair this another interesting session is we have Dr. Savita C., Professor and HOD, Vani Vilas Hospital, Bangalore Medical College and Research Institute. Can I have the slide, please? Dr. Savita, she's been a mentor and a guide to countless undergraduates over the past 21 years, and hundreds of postgraduate students have passed out under her supervision. A CAC trainer, a NACO expert trainer, examiner for UG, PG, and DNB students. She heads the high-risk pregnancy fellowship in the prestigious Bangalore Medical College and Research Institute, member of technical advisory committee for the government of Karnataka. In fact, today she was very, very busy with the government program with the minister. She said, I'm so tired, but then she's been so pleasant and graceful to be with us in this session. She has led the fight against the COVID for pregnant women for the first time in Karnataka. And we have seen that during the first pandemic, there were hundreds of COVID positive women who were pregnant women who were admitted in the Vani Vilas Hospital, and tens of her postgraduates became COVID positive, treating this COVID positive mothers. And she has led a team who have delivered more than 1,000 COVID positive mothers till date. I think she will have the biggest database for conducting the deliveries in COVID positive patients, presented and published numerous papers in national and international journals, and ex-syndicate member of the Rajiv Gandhi University of Health Sciences. A warm welcome to Dr. Savita, and thank you for accepting our invitation to chair this session. Over to you, Dr. Savita.
Thank you, Dr. Rajeshri Madam, for that wonderful introduction about myself. Thank you. And just one word about Sarina Madam's talk. It was really crisp and simplified. Very, very wonderful. And congratulations and happy Women's Day to all of you who are online now. And our next speaker will be Dr. Shobha Gudi, Madam. So she is popular all over India, especially after becoming the chairperson of the Family Welfare Committee. She's a professor and HOD at St. Philomena's Hospital, Bangalore, postgraduate teacher and examiner. She's a chairperson for the Family Welfare Committee, FOXI 1921, President BSOG 2018-19, assessor for a GOA project, that is the Laksha project, board member of FPAI, peer reviewer of Jogi, GCM, ICOG 21-22, EC member of Kasoga, and she's the editor of book Obstetric Hemorrhage, author for FOXI Focus GCPR, publications national and international, many are there, awards. She has won the CL Javeri Symposium 2015.
This is where I say, Savita, because
What?
I think I am cleverly very late in stopping you, but at least now I must do. And what I have done in my lifetime is nothing compared to what you do. So I don't think it is kind of. Okay,
Welcome,
so
Madam. Welcome for your next
thank you, Savita.
talk.
Thank you. And thank you for coming and listening into my talk on contraception. My body of work on this subject is a minuscule of what you have done for family planning for those countless women who approach the public sector for their, maternal care, maternity care, And I think that you run many successful programs on family planning, as well as you conduct training for CAC services for PPI-UCD. So I have always had a very high degree of regard and respect for my colleagues who are in the public sector. But I always believed that government's work is God's work.
Thank you, madam. Thank you.
Yeah, what we are doing is, a more fragment. But then, as far as family planning is concerned, I think that must change. And I think the time has come, because repeatedly I get the vibes from higher government officials like Dr. Sikdar and many others that FOXY does not do enough for family planning. And that is something which I attempted to change in the past 2 years. I may not have succeeded much, but I might have just, succeeded in increasing the awareness of people for this underserved segment of our specialization. So I hope my screen is visible.
Yes.
Yeah. So when
Yeah.
Rajeshri told me that I must speak about the practical aspects of contraception prescription through case scenarios, I felt that she's doing the right thing, because I feel that nothing is better than enabling the prescriber's capacity to write down a prescription for contraception at every opportune moment. And we know that there are a lot of women who deserve contraceptive advice and family planning advice, and many of them do not get it in time. So here goes. I will be crisp. I cannot compete with Sarina madam for preciseness, but I will try my level best. So we all are aware that there is a skewed pattern of contraceptive usage in India. And we know that most women opt for terminal methods, and most of them are the female sterilizations. The male sterilizations are abysmally low, and the modern spacing method, they do not get the focus that they deserve, and they are underutilized when we compare to the global scenario. The traditional method gets used more often, and that is why we see more of unintended pregnancies. So it does look like 60 to 70% of women use various methods of contraception, especially after the NFHS 1920 has reaffirmed that. Any problem? Am I audible properly?
Yes, ma'am.
Okay. So NFHS 1920 has told us that there is the contraception prescription prevalence rate is between 60 and 70 now, maybe closer to 60 if we are very truthful about it, whereas earlier it was only 50 or 52 or like that. So that is good, but we need to cross 70%. So the latest is a little higher than 60%. And the non-contraceptive users, of course, are more than 40% even today. So that has to change. And as I just spoke to you, that many methods are underutilized. And I must bring to your notice here, I also already spoke about this skewed pattern of usage in India. But I must just highlight here that may not be the male sterilization, but definitely the pill and intrauterine devices, especially the hormone containing, the barriers, and also the implants, which is not featuring here, are having really very high usage in rest of the countries, in rest of the world. And it is not only the developed world. In many developing countries like the African countries, the Far East countries, the now here when you see on the left side, you can see the percentage distribution of oral contraceptive users by fertility preferences, and you can see that with respect to choice of contraception method, 94% of women do take part in decision making, but it does not translate into accepting the method. So somewhere down the line, we fail to ensure that there is a service. And therefore, what all that needs is there is a huge gap in the service, because there is a very strong medical need for contraception. Okay, I'll stop.
Yeah, there is a disturbance from some other. Can you please mute the others? Okay, ma'am.
Yeah. So we can see that there is a large number of unintended pregnancies. You must have heard speakers say time and again that almost half of the pregnancies occurring at any given point of time are unintended, and it stands true. Unfortunately, the latest NFHS 1920 also does not show any decrease in the number of unintended pregnancies. And once there are these pregnancies, we all know that there is a lot of abortion, which happens, both safe and unsafe abortion. And the estimated rate of unintended pregnancies are as high as 70 pregnancies per 1,000 women in reproductive age group. And ideally, if the unmet need is met, then this drops down to less than 15 or less than 10. And that is when the unintended will be at the lowest possible. This is an important tool for contraception prescription. All of us must have it on our desk at all times. Both this and the ready reckoner chart. Now, this is the MEC wheel, and there is a particular method of using it. And actually, it is a very kind of sufficient tool for contraception prescription, because there are methods outlined here, the categories are here, the life situations are here, the medical conditions are outlined also on the disc, and on the reverse side, there are these, superscripts, which are explanations have been given. So there is a whole lot of nuancing and detailing to be done when we use MEC category, and we are all aware today that 1 and 2 means in general the method can be used, and 3 and 4 means that it do not use the method. Now, when we say that this is a MEC criteria, it is taking all three parts of the triangle, the Bitzer's triangle, into account. It is the woman in her life phase, with or without any medical complicating conditions, and as against the method. So it takes into account all the 3 components. Now, when we speak about hormonal contraceptives, we are aware about the combined pill and the combined hormonal contraceptives, be it the pill or the patch or the ring or the injectable and the progestin-only contraceptives. So we need to start learning about each method, and time and again we must go repeatedly, and we must refresh our knowledge about the newer methods which are coming into the market at all times. We know that the pills need to be taken daily, and we know that there is a very low dose of estrogen and progestin which gets released, which gets rapidly cleared on a daily basis, and that is what makes the pill very safe. And the progestin only is also safe in the breastfeeding women. Okay, and it should be taken daily. Women on combined pills, that is why I am repeatedly saying is that women often fail to realize that when they are prescribed, and they try to relate it to their sex practices, but they must know that they should take it throughout the month, and not only during the period when they are sexually active. So the types of progestogens in the combined oral contraceptive pills have seen a lot of evolution in the past 2 or 3 decades, and we have found that all of them have proved to be very women friendly. In general, COCs show higher continuation rate versus POPs. That is true, because POPs are actually plagued with more and more breakthrough bleeding, but the newer preparations are overcoming that. The 3rd generation COCs are less likely to be discontinued versus the 2nd generation. So let us remember that the desogestrel containing and again the drospirenone containing COCs are less likely to be discontinued. So the beneficial effects are far beyond contraception. We all know that women can get relief from overbleeding. They have ovarian suppression, and symptoms of menstruation improve. And this is a 24-year-old lady, and she wants to postpone her plan of expanding her family by a year. And the newly wedded couple have been using barriers, but as most newly wedded couples, they are not liking the idea much. And she is always feeling that she might be pregnant because she has some irregular periods, and then she cannot get over that apprehension. So therefore, in such a woman, it is very useful to get control of the cycle with a combined oral contraceptive pill. And we can see that they are highly effective, ethinyl estradiol and desogestrel containing drugs. These are some data supporting about the efficacy and about cycle control. So I think these are more scientific data, and we need not go into the details in a clinical discussion. if I ask you the question in your clinical practice, how often do you use COC? And if I ask you the question, how is your experience with the ethynyl estradiol plus desogestrel or ethynyl estradiol plus drospirenone, I think you need to come up with some commitment, some answer. And if you are having a steady practice of say 15 to 20 women passing through your clinic every day, you will have the chance to prescribe contraceptives to them, either for contraception or for both contraception and gynec disorders, or only for gynec disorders. And you will have some experience related to these questions. Now, the benefits of combined COCs, I think this is something we have been learning from the time we were medical students. We know that it improves menstrual symptoms. It improves the discomfort associated with menstruation. It also improves hirsutism and acne, and it improves the symptoms of endometriosis and chronic pelvic pain. And of course, it prevents against pregnancy, but it also protects against cancer. Now, how many drugs are there except for the HPV vaccine which can claim to prevent cancer? Hardly any. But COC has that might, it has that strength, it has that power to prevent endometrial cancer, to prevent cancer of the ovary, as much as 50%. Okay, as much as 50%. And this is something we are not telling our women, and we must tell them. Of course, there are other beneficial, the dessert which comes with the meal. It also protects against anemia, it protects against formation of ovarian cysts, etc. So here is a 29-year-old, and she's complaining of some, irregular cycles and lot of fatigue. And then we find that she's anemic. And she also wants birth control. Very imperative, don't you think, that we must give her birth control, because we don't want her to be with an unintended pregnancy when she has anemia. So of course, the first step is to find out why she is anemic. And of course, we must take every measure to correct her anemia. And of course, her diet and nutrition, which will be 100% will not be appropriate. So we address all those issues. But when it comes to contraception, we need to realize that that COCs have got a special benefit for women with anemia, because they also decrease the menstrual bleeding and decrease the duration of the cycle. And these are some studies to support that statement, that it improves hemoglobin and iron storage as well. It improves the iron stores as well. It is not only in iron deficiency anemia that contraceptives are beneficial. It is also in sickle cell disease, for sickle cell anemias, for example. We can see that there is a special, benefit of the injection, the implant, and the progesterone only pill, the progestin only. It is also surprising to see that copper IUCDs are category 2. Many of us might hesitate to insert a copper IUCD whenever a woman presents with anemia and is under correction or treatment for anemia. Well, let me tell you that it is MF category 2. And suppose a woman picks up the copper IUCD in the basket of choice that you are offering her, there is no need to hesitate. We can always insert the copper IUCD. This is again, I think, a repeat. We'll go on to this 26-year-old. She has been a regular menstruator, but in the past 1 year, she had a little infrequent. She had oligomenorrhea. And when you actually look at her, she also says that she has gained some weight. You see some androgen with considerable Perriman-Galloway score, because there's chest hair and all that. And she's also having some acne, and she's cosmetically very conscious. And, she's not very happy because the husband has started commenting on her appearance. So when we look at that, we also evaluate which particular progesterone will benefit her. And then there is overwhelming evidence today that desogestrel containing drugs and drospirenone containing drugs, they have got sufficiently enough anti-androgenic activity to give relief to such girls. And especially true, though this slide is supporting the desogestrel, but I must tell you that both desogestrel and drospirenone have high selectivity index for androgen receptors, and they have high progesterogenic affinity as well, and they are really beneficial to women, and they do result in increase in SHBG, so that it binds off to the biologically active free testosterone fraction, and that is because of the effect of the estradiol content of the medication, and they also benefit with the peripheral action of the progestogens, so that there is a decrease in the acne and decrease in the hirsutism. Okay, and we do see that 6 months of treatment with such medication will result in at least 40 to 50% benefit of acne, and maybe 9 months of treatment will result in benefit of the hirsutism. So when we are treating women with polycystic ovarian disease, it is not only important to put this prescription, but also the lifestyle modification. And I don't think to the elite audience today, I need to tell how to manage PCOS. Of course, it is LSM first, the lifestyle modification, followed by drug therapy. But there is a skill about prescribing GOSI pills to such women, and there is a requirement for counseling and follow-up, because these hormones are of immense benefit. A 28-year-old woman, she has irregular bleeding, acne, weight gain, and also headache. And she was prescribed, she has a 2-year-old boy, and she is prescribed an LNG IUS device for contraception. Okay, she has been prescribed by somebody else, but she wants to consider other options for contraception. So when women come to you and they have some kind of fear or ill feeling towards any particular method, we must try to sort out that. At the same time, we must offer her a very large basket of equally effective contraceptive methods, so that she has a lot of options, and then she is able to choose the best one. So here again, probably the oral contraceptives will benefit this woman, combined pills, because she has all the setting for hyperandrogenism. So we shall go ahead with these are some comparisons of levonorgestrel containing drugs and desogestrel containing drugs in women with the premenstrual syndrome, or women who have premenstrual dysphoria. In the symptoms for negative mood and are less, negative sexual thoughts are less when desogestrel is used as compared to levonorgestrel. But I feel that these differences are minor. But by and large, for premenstrual syndrome, the progesterone which is friendliest is, of course, drospirenone. So drospirenone containing combined oral contraceptive pills will be of special use for women who have premenstrual symptoms. Now, about the quality of life and weight gain for women who are on combined oral contraceptive pills, we need to understand that weight gain is not directly related to the drug use, and it is more of a lifestyle factor. There is enough evidence to say that. So this is a 32-year-old lady, and she has come seeking tubal sterilization, and she has a 7-year-old and a 6-month-old, and she has conceived despite the calendar method. That means that she was not using very effective contraception, and it is important to give this woman the entire basket of choice if she desires a non-permanent method, but she is desiring tubectomy. So there is no harm in going ahead and performing a tubal sterilization for her. Okay, then we will go on to this lady. 33-year-old wants contraception. She has an 8-month-old baby girl. And this pregnancy, she's 33-year-old, mind you, and she had conceived only through IVF. And then she had diabetes also, and that was actually, only diet management was required. In postpartum, of course, everything was normal, but when she got herself evaluated, there is an increase in low density cholesterol also, that LDL also, dyslipidemic, but she has not been on any treatment. So in this woman, of course, we need to again look at the dyslipidemia, bring in lifestyle management for that, get her evaluated whether she needs to go on to statins, and we also address her contraception. We must never believe that women who have had infertility will not be able to have an unintended pregnancy. Several times we see that however difficult the pregnancy might have been to achieve in the first place, postpartum, within a year, some of them do come back with pregnancy. Okay, so when it comes to lipid profile, there has not been any change in the total lipid, LDL cholesterol or total cholesterol when women are given combined oral contraceptive pills. And since the child is now more than 6 months old, so the COC can become one of the choices. So also will POP, so also will injectables, and so also all other drugs. So I must go ahead with this slide, and this is the WHO slide for diabetes and contraception, the MEC criteria for endocrine conditions. And it is, you must just, when you look at, just do an eyeballing here, except for this particular segment, the entire thing shows category 1 and category 2. So there is no hesitation for contraception prescription for diabetics at all. When it is GDM, everything is category 1, and this is ACDS criteria for sterilization is A. When it is diabetes who are insulin dependent also, most of it is category 2. And you can see that the copper IUCD is the winner. It is 1 throughout. But having said that, you can't just advise copper IUCD. So often when we ask postgraduates, they feel that if they say something non-hormonal, then they will pass. Well, of course, they are right in thinking, but they must understand that we never prescribe one method to the woman. She should realize that there is a basket of choice, and when we offer and she picks up, that is fine. So we must realize here again that though she is on insulin, she can still take all the hormones, whether it is progestin only or combined, and she can have the LNG-IUS also. And if she requests for sterilization, then she is category C, that is caution. That means that she has to be done after adequate control of diabetes. Whereas if the women have vascular complications of the kidney, eye, or neuropathies, the estrogen containing medications and probably the progesterone only injectables, the dipomedroxyprogesterone acetate, are not good choices for her. They are category 3 to 4, whereas other methods are okay and the sterilization is special. Other vascular diseases or diabetes of more than 20 years duration will also preclude the use of estrogen containing and the injectable, whereas other methods are okay. When you come across thyroid disorders, you can see that nothing is a problem. Nothing is a problem. Everything can be given, but the woman should be euthyroid with your treatment, or should be an endocrine consultant or a physician's consultant. 29-year-old, 1.5-year-old baby girl, LNG-IUS for 3 months. Just for 3 months. She has been inserted 3 months back, LNG-IUS. But after that, she is going on having unscheduled breakthrough bleeding, and she's unable to cope. She's unable to cope with a small child running around, and she's having so much of spotting, and she wants a different option. So when we do ask this question, many practitioners, and if she walks into your clinic, the first instinct would be to treat her with removal of the LNG-IUS. Well, let me be clear here that LNG-IUS in the first 3 months, by nature, it may produce a slight unscheduled bleeding. And if the woman sticks to the method, this is an excellent contraceptive method, which will give her protection for the next 5 years. So please do not remove the device unless 6 to 8 months have passed by and she is really not comfortable. But at the end of the day, it is her right to ask for removal if she is really not preferring. So if you remove, you must provide her the other method after she has chosen it from the basket of choice. These are slides to say that combined pills actually do not cause any breakthrough bleeding. Well, that is very true. All the combined pills that we have they are the best tools for cycle control in women. Combined hormonal pills with low doses of estrogen and progesterone give the best cycle control and the least menstrual symptom for women. And do consider them when women are struggling with coping with menstruation or irregular bleeding. Okay. About breakthrough bleeding, this question is about breakthrough bleeding. Well, the lower dose containing the estrogen content, if it falls less than 30 microgram per day, it becomes 20 or 15 microgram per day, there is higher incidence of breakthrough bleeding. There is higher incidence of breakthrough bleeding. Also,
the progestin only contraceptives like the injectables and also the implants, there is higher incidence of breakthrough bleeding, but most of it can be sorted with counseling and with smaller measures and so short durations of agents like mefenamic acid, etc. Now, this is a newly married couple, and they have come with an unintended pregnancy, and she is absolutely not ready to become a mother, and she requests us for an abortion. I think there was a time, and I think Savita would agree with me, and so will Rajeshri, that and so will Dr. Kasturi also, that there was a time when we all used to feel that primary gravida should not abort, and we used to tell, no first pregnancy, please keep, please continue, please deliver off what is there, you're married, and after that you can put a spacing. So those days are gone, and whenever today whenever they come, we have to counsel them, we have to tell them the effects of an abortion, and then once she has determined that she wants to go ahead, we have to give her respectful abortion care. So we can ask why not using contraception, but we cannot be judgmental. We persuade them to change their decision. I don't think so. Highlight the side effect of abortion, yes. Discuss the abortion options, surgical and medical, and counsel and send them home to rethink may not be a good idea, because they may not come back to us. It has happened to me. It has happened to me because I may think that I am justified in asking them to wait ethically, maybe, but it's a wrong thing to do. Refer to a colleague, because we don't do abortion. Some of my colleagues do that. They do not undertake MTP. I understand if they have a principle, but then we are failing in our service if we do not provide safe abortion. To being an Indian obstetrician, there is some onus on us. Because why is the woman in that situation? Because contraception has not been prescribed to her, good counseling. That is why she is in that situation. So the onus, the responsibility is on us as well as on the couple. I'm not saying it's only on us. So this should be treated as an excellent opportunity to counsel for post-abortion contraception. That is the most important message I want to give, that never lose the chance for prescribing contraception when women come for abortion. Okay. She is in a very delicate phase now, because she has gone ahead and terminated a pregnancy, and it is likely to have impact on her, because after all, she is a woman, she also cares, but she was not ready for the pregnancy. So we need to integrate family planning with post-abortal care as part of CAT, comprehensive abortion care, and that is happening. And it is important to break this cycle, because why is there unintended? It is because non-use of contraception. So abortion services should be provided, and contraception, because if we don't do this step 4, then the cycle will get repeated. We are all aware. So break the cycle, please. And then the couple was sent home to think, and after they returned, they wanted a medical abortion. She was A negative, and we went ahead with all the drugs, and all right, so we did all this, okay, and she finally had uneventful, and she was started. So when we come to post-abortion, first and second trimester, everything is possible. Please understand that proper IUCD can be placed in a woman who has had a second trimester abortion also, because we are doing postpartum, then why not in post-abortion in large uteri? And as far as all these methods are concerned, they can be provided along with the misoprostol prescription. They can all be provided. The only thing we need to remember is that the abortion should be complete. You verify it is complete, and there should not be any infection, and there should not be any injury to the genital tract. Then contraception is perfectly safe. 33-year-old woman is an executive, and we find such women today in our practice. And she's probably completed her family, but she doesn't want to undergo surgery. Well, what should we advise her? So actually, I keep this as a chocolate question, and most of them, start with saying long-acting reversible contraceptives. But I think if she doesn't want surgery, probably we can ask her husband if he can undergo a small procedure of NSV. And if that is not possible, then we can look at her giving her long-term options. So this is how it goes. One of the methods can be chosen, including the implants. And then we need to know the SARC versus LARC concept, that the SARC methods, the short acting reversible contraceptives, which we have used, we have spoken of till now, the hormones, they do require more effort and more continuous troubleshooting and more nuanced information, and there has to be a lot of commitment for the woman to follow with good compliance, and also for the care provider. Whereas the LARC method is more like a fit it and forget it, and there is a high continuation rate, and there is a less incidence of failure and less incidence of unintended pregnancy. Okay, and they are also advantageous because they do not have estrogen, and they are very safe in women who are have contraindications for estrogen, like hypertension, etc. So we have these currently in our armamentarium today. You're familiar with this, you're familiar with the progesterone, you're familiar with the injection, and this is subcutaneous version of the progesterone only injectable contraceptive. And then we have this, and this is the subdermal implant, and we have been inserting implants for the past 2 years, and they are very good. So you can see this failure rates, and you can see that it is very, very low, very, very low with the LARC methods. You can see that because there is not much difference between the typical and perfect use. That is the biggest advantage. And you can see the implant, probably this failure rate of 0.05 is even lesser than the sterilization. That is what it shows. You can see, because when we do a tubectomy, we tell them 1 in 200, don't we? Failure rate, but implant it is lesser. It is 1 in 2000. It is that much less. So injectable contraceptives, Antara is a big hit in the public sector today, and we acknowledge that, and we acknowledge the hard work of countless, hundreds and thousands of healthcare providers who are giving injectables to women, including the ASHA workers who are counseling for it. But the subcutaneous version is there today, soon to be included into the government sector, but was first brought into India by Pfizer. And it was not costing much. It was around 400, 500 rupees, and it has 30% lower dose. And what can be better than having 30% lower dose, only 104 milligrams, and having equal efficacy? So that our worry about bone mineral density, etc., will go away. Probably the side effects also will come down, and it is there in the essential medicines list, etc., for WHO. This is how it looks. Disposable with a reservoir, very simple, self-injectable after one training, and it is really very useful in situations like the pandemic. Okay, so all right, so then we go on to this concern for DMPA, and we must know that all ages it is quite okay. It is reversible loss. There is no restriction unless a woman is already suffering from obvious osteoporosis. I have not seen anything like that till now. The only place where we need to be careful is in young girls, and POXO is protecting us from that, because we are not supposed to prescribe contraception for young girls. We can only counsel them. But that is the age group in which DMPA's effect on bone density is not well researched. The long-term effects are not well researched. We've spoken about the implant, so I will just skip through these slides only for orientation and alertness. There's a 3-year device, gives protection for 3 years. It is subdermal, and it is really novel, and it is external. That means it's away from the genital tract. It's disposable applicator. Subdermal, contains only 68 milligrams of etonorgestrel. 39-year-old woman, obese diabetic on medication, also has AUB, and also is at risk for pregnancy. She wants to ask you about contraception, and of course, all of you will say LNGIUS, but first she needs evaluation of the AUB. We need to find out whether she has any real endometrial disease and any other myometrial disease, etc. And we need to treat that with appropriately, and also prescribe her contraceptives. So LNGIUS can give her protection and can give her relief, but so also can other medications. All of them have been used in AUB, including the non-steroidal contraceptive or meloxifene, the Chaya. All of them have been used with good success, but the evidence is, please do not think of endometrial ablations as a method of contraception. It is not, and it is also not therapy anymore. It is less and less used today. About the low dose OCPs, I wanted to say something that NICE guideline endorses the primary use of oral contraceptives, low dose oral contraceptive pills for the reliefs of abnormal uterine bleeding. It can be the first line treatment. Especially when there is no complex hyperplasia, there is no ATPA, etc. For proliferative secretory endometrium, for simple hyperplasias, oral contraceptive pills can give excellent relief. We must always remember that such conditions for the woman are self-limiting, and they do go away in time. And 5 years of LNG-IUS may prove to be over treatment for some of these women. Okay, so that is a question where hormones are contraindicated at 39 years. Well, no, they are not. This is another useful tool, is a pregnancy checklist. And when women report with unprotected intercourse, or they report with amenorrhea, or they report with suspicion of pregnancy, then we use this 6-point checklist. And if the client answers no and pregnancy cannot be ruled out with the checklist, then we have to do a test. But if she says yes to any one of these questions, then we need to we can go ahead and prescribe her the contraception. We can go ahead. This is a slide on 1 minute. Please excuse me. Please excuse me. Please. Hello. So then, in the postpartum situation, we do not prescribe them before 6 weeks. We do not give them progestin only. The only thing I would like to change here is the implant. It is category 2 and not 3. But otherwise, and also the POP in breastfeeding women, it can be given earlier. But otherwise, everything else is okay. The copper IUD cannot be given before 48 hours. Yes, after 48 hours to 4 weeks, the copper IUD cannot be given. But otherwise, most of the methods can be prescribed to postpartum women. When they cross 6 weeks, everything becomes okay for them. And when they cross 6 months, then even the COCs can be prescribed to them. When they're not breastfeeding, of course, even COCs can be given after the 3 weeks. So that is how the basket of choice is very, very huge in postpartum women. So this woman who is postpartum seeking contraception, when we examine her, she shows a hypertension. And she says that she had preeclampsia during pregnancy. So will that chart change when women have hypertension? Will it change? So we know that combined oral contraceptive pills cannot be prescribed to women with cardiovascular disease and hypertension. It will increase the risk of further complications in them. But progesterone only pills can be given. And if injections are being contemplated, if the woman is choosing, it has to be a very well controlled hypertension. If it is inadequately controlled, the injectables also cannot be given. So this is the chart for hypertension and contraception. And you can see that the estrogen containing medications are category 3. And the others are category 2, and that is how it goes. That is how adequately controlled hypertension, even injectables can be given. But if it is inadequately controlled, as you can see here, the injectables cannot be given, but others. And please remember that all these women are highly eligible for contraception, because they should not conceive when they are going through a poorly controlled medical disease. Here comes an adolescent, and she is just 18-year-old school student. So the heavy recommendation is, when they come seeking contraception, first verify the age, and ask for the Aadhaar card. It is not only her, but also her partner. So we need to find out about that. And Should we tell her to concentrate on her career? No. Ask her to bring her parents the next time? No. Should we advise barrier contraception? Yes. Should we advise low dose OC pills? Yes. So she requires dual method. Should we explain the use of emergency contraception? Yes, yes, and yes. So all that is necessary for an adolescent. We must not be judgmental and no need of preaching. So we have changed also in our approach to women's girls seeking contraception, but they have to be more than 18 years of age. Okay. All right. So it's important to choose a less androgenic progesterone for young girls, and additional non-contraceptive benefits should be looked for, low doses of estrogen. And of course, adolescents have less paying capacity, so it should be affordable, available, and acceptable, all those things. When you start taking her history to see if she's suitable for contraception, then she says that, because remember, she is very young, she has just completed 18 years. She says that she remembers her mother's second pregnancy when her younger brother was born and the mother had developed DVT in her pregnancy. So does it change anything? So when there is a family history of DVT, which we do find, then there is no problem in prescribing her any method. In addition to the only thing we need to rule out is her own tendency, because remember, the mother developed with a trigger factor, with a background. So in her, we can rule out the tendency of thrombosis. If the history is clear, if she has no history like this, then she can be prescribed. But if she has a history of any of this, she cannot be. And then there are women with Apla syndrome, women who have prolonged immobilization, known thrombogenic mutations. In them, of course, we cannot prescribe COCs. So this is probably one of the last cases, 29-year-old, actually nulliparous and recently married. And she does not want the pill, and she's afraid of the intrauterine device, and she has heard of the vaginal ring, and she's wanting that. So we've got clients like this also, who are informed, well read. They would have gone through literature, they would have read about a method. So when they are already having a notion about a method, I think it's important to encourage, at the same time telling them the alternatives, but then we can encourage. Okay, so we need not advise her otherwise. All this may not be necessary. Not to defer pregnancy, no, not necessary to tell her. Not to get carried away with media buzz, not necessary to tell her. We can provide info on the ring and help her make an informed choice, at the same time discuss other. So there are facts and myths, that is okay, because most of us we don't have availability here, so I would like to skip that. Now this lady, just before we finish talking to her about the ring, etc., the husband comes in and he tells you that he has been HIV positive and ARV therapy, which the woman never wanted to divulge, but the husband couldn't keep out. He felt that he has to declare, because he wants to know whether the medication is safe for her. So then we ask for our patient's HIV, and it comes positive. She is HIV positive, though she has no symptoms. So she is WHO stage 1 HIV. So now what to do? What contraception is she eligible for? So can you see here that women who are at risk or asymptomatic or mild disease, we can prescribe her anything. There is no change. But if she is on treatment with antiretroviral therapy, especially the nucleoside reverse transcriptase inhibitors, then I think there is some reservation that she is a little more advanced HIV. So local methods we may find it difficult, but actually everything else is okay. Now, when it comes to NNRTIs, the efavirenz containing drugs, then the hormones are all category 2 and not category 1 as the other drugs, but still they can be prescribed. Okay, so that is the lesson learned about HIV. Especially the injectables have found a lot of place for contraception in women who are on HIV medication. And one simple reason could be that local methods are less preferred, like IUCD. As I told you, they are category 2 bar 3. For continuation, for initiation, they become 3, and also the And the combined oral contraceptive pills, though they are category 2, the woman is also already popping so many pills, isn't she? So there's more likelihood of her missing, etc. So it's better to give her injectable, better to provide her as some kind of LARC system, like an injectable or an implant. Then we have the sexually transmitted infections, and you can see the hormones gain the upper hand here. So then we finish with this statement that risk of unwanted pregnancy is always higher than use of any contraceptive. I just wanted to say here that the MEC category criteria, the medical eligibility criteria, are restrictive, are regulatory, they're not restrictive. Now if we use it nicely, very intelligently, then we will find that in any given situation, we can find some contraception for women. So high risk situation, MEC category are regulatory, but they are not restrictive. In every situation here, you will be able to find a basket of choice, not just one method. You will be able to offer her a basket of choice. So discussion on contraception forms an important part of our clinical practice. Please remember, informed choice is the key to success for counseling and regular follow-up. Every opportune moment should be taken to discuss contraception. And if we keep on doing it, I think we also get used to it. So please, at the end of the day, I think all of us have to evolve to that stage where at the end of the day we reflect on what we have done with our patients. So we can kind of ask ourselves a set of questions, a set of moral checklist. When we were younger, we were told to pray every night and ask pardon for our sins, etc. Well, we are not doing that, but what we can do as obstetrician is having a moral checklist. How many pap smears I did today, how many women I counseled for contraception, how many copies I inserted, etc. So and how many anemias I picked up, and how many diabetes I picked up. So like that, we can keep a quality check on ourselves, and that will go a long way. Well, setting up private family welfare clinics, and the committee has long wanted to start an eye care clinic in every private setup. Maybe someday I will bring home to you that. The birth control is the first important step a woman must take towards the goal of her freedom to become a man's equal. And it is the first step both man and woman should take towards human emancipation, because one has to control the number of children. This is something interesting which UN Commission on Life-Saving Commodities has put in place as long back as 2012. And it is, you can see that the life-saving commodities for reproductive health and maternal health. And when you look at maternal health, you can easily count off the medications which save mothers' lives: the oxytocin, the misoprostol, the magnesium sulfate, maybe other prostaglandins, etc. But when it comes to reproductive health, can you believe that life-saving commodity can be a female condom? Because it protects her from an unwanted pregnancy and an unsafe abortion. It could be a contraceptive implant. It could even be an emergency contraception. It could even be that. So let us remember that family planning is life-saving, and at all times the woman needs to be befriended, because she is essentially a well woman to whom you are prescribing medication and doing procedures, etc. She is not a ill woman. So that is how public health differs from clinical health. She needs to be an awakened Indian woman. She will be a better acceptor. Our services must be client-centric and not, center on how much time we have. We should see that we do justice to her. Contraception FP services must be integrated with maternal health care, with every other health care, and should be made cost-effective. And the momentum of improved FP indicators must not be lost. So please remember that the latest NFHS 1920 has evaluated indicators as the number of abortion, contraception uptake, maternal mortality, neonatal morbidity and mortality, etc. And they have found that they are all directly linked to family planning services. Giving a woman choice of birth control options, giving her a choice of birth control options is not only a family planning and health issue, it is a matter of social justice, and it is an equity imperative. Today, we know that the theme is gender equality. So let us believe that this is an equity imperative, and we must do it right and do it now. So therefore, FP alone can bring more benefits to more people at less cost than any other single technology now available to human race. And let us believe that. And with that, I end my presentation. Thank you very much. Thank you.
It was a wonderful presentation, madam. What I feel is especially your MEZ wheel. MEZ wheel, everyone should have on their table for the quick reference, and even the postpartum contraception. We come across very often, women come with that for the advice. So that should be on the table to give them the proper advice.
Thank you, Savita. Thank you so much.
Over to Rajeshri, madam.
Yeah.
I think that there are some questions in the chat box.
I don't see any questions as of now.
Okay.
But I think the presentation was so good. It was of such high caliber that everything was made very, very clarified with quotations and references. It was a superlative talk, madam. And although oral, I mean, the contraceptive practices, choices, and talk are always very, very dry topic, but it is so important that each one of us are aware as to case-based relevant conditions, what to practice and what not to practice. And just as Dr. Savita mentioned, the Ready Reckoner becomes a very, very useful tool. And I think many times the medical reps, some of them, they come and give, and we just offhandedly throw it away, not considering the significance and importance of it, because it is written in such a minute lettering. But yes, it's time that we rise up, and as Dr. Shobha madam mentioned, that the sexual practices and preferences are varied, and now we really can't say the girls what to do and what not to do. And I'm sure in metros it's very, very rampant now. We hear of many incidences wherein the girls, even the teenage girls, go for unsafe sexual practices and contraceptive methods, and most of them end up with life-threatening scenarios and infertility issues and reproductive failures. So it's more so the need of hour that all of us are more aware of this very important topic. Thank you so very much, Madam Shobha, for delivering such a very... Yes.
Thank you. It was wonderful being with Kalburgi Society.
Thank you so much.
Especially thank you for this invite. Thanks a lot.
Thank you.
Thanks, Savita, for sharing. Thank you.
Thank you, madam.
As you said, Savita, I think she's the youngest HOD in a government sector, and doing a very, 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 very responsible and important job.
Yes, she's doing
I feel proud to be associated with her because she's done from Gulbarga.
Yes.
She's a student.
Okay.
Yeah.
Okay.
Close family friend. Yes. Thank you so much, Savita.
Okay.
Thank you. Thank you.
Thank you, ma'am. Thank you, Savita, ma'am. Thank you. And thank you for all the speakers and the chairpersons for sharing this in spite of their busy schedule. And if Rajeshri ma'am would like to add on any word to today's note.
I think everything has been covered. Over to you, Dr. Harsha, to please propose the vote of thanks.
Yes, I would like to call Dr. Harsha ma'am to give vote of thanks for today's session.
Good evening, everyone. At the outset, I wish everyone a very happy Women's Day. I thank our first speaker, Dr. Sarina Gilwaz ma'am, whose talk was very, very informative on hyperglycemia and pregnancy, ma'am. It's no more GDM. So thank you, ma'am, for giving us so many new updates, and thank you for making this confusing topic so very crystal clear. And I thank Dr. Kasturi Donimat ma'am, who is also my beloved teacher, for chairing this session. And I thank our next speaker, Dr. Shobha Goody ma'am, for an elaborate talk on contraceptive practices, especially the case scenarios, ma'am. Indeed, we got many practical tips in your talk. And I thank Dr. Savita ma'am for chairing this session. It was definitely an academic feast on this Women's Day. Thank you, dear speakers. Then I thank our president, Dr. Rashri Paladi ma'am, our organizing secretary, Dr. Sanjana Talur ma'am, and Dr. Sneha for organizing this wonderful CME today. And last, definitely not the least, I would like to thank all our delegates for logging in and making this webinar a grand success. So thank you one and all. Good night.
Thank you, Chitra Shield, for always being our partners for the webinars. And thank you, Harsha, the treasurer of OBGYN Society, for giving the vote of thanks.
Thank you so much, ma'am.
Yeah.
Good night.
With the pandemic ending and diverting the attention of the world towards something more important or maybe less, we don't know what scenario we are in, but what we see is that we are out of the pandemic, maybe, hopefully, and then we hope to meet each other during the physical CMEs. And I'm going to Indore. I hope to see many friends there. Yes. Thank you so much.
Yeah,
it was a pleasure to be with you all. Thank you.
Thank you for the opportunity, Dr. Rajeshri, madam.
Bye. Bye. Good night, everyone.
Good night. Good night, everyone.